So, very good evening to you all, and a warm welcome to another episode of the NCSI Bulletin, which is a part of the e-educational series of the Neurocritical Care Society of India, where we are going to dive deep into advancements in neurocritical care guided by well-known experts. So, today we'll be presenting an interesting article on remote ischemic preconditioning to prevent delayed cerebral ischemia secondary to aneurysmal subarachnoid hemorrhage. I hereby welcome today's speaker, Dr. Shreyosi, who is a final year DM resident from PGI Chandigarh. And the moderator for today's session will be Dr. Amya Kumar Bariksa, who is working as an associate professor in PGIM at Chandigarh. So, very warm welcome to you both. Before we delve into the current study, we would like to present the Journal Watch, where we are going to bring to you some of the latest articles, novel concepts, and some policy changes in neurocritical care which have been published by leading journals in the field. So I'll be, very briefly going through some of the articles. So our first article today is the recently published Starship study. So the Starship study studied the trends in autoregulation in severe head injury in pediatric patients. Now, as we know, cerebral perfusion pressure is widely acknowledged as an important therapeutic target in pediatric TBI. And the current BTF guidelines advocate a fixed lower threshold of 40 to 50 millimeters of mercury, which is presumed to represent the lower limit of autoregulation. However, if you look closely, you will see that it's based primarily on all these retrospective studies. So whether the cerebrovascular autoregulation guided CPP targets are more closely associated with outcome was what this article was all about. So the authors conducted a prospective multi-center observational study where they inserted intraparenchymal ICP probes and used the ICM plus software to define the to obtain the pressure reactivity index and define the lower limit of autoregulation as the cerebral perfusion pressure where the autoregulation was already impaired. That is the PRX, the pressure reactivity index was 0.2. They found that all these patients who suffered an unfavorable outcome at 12 months had a greater hourly dose of CPP below the lower limit of autoregulation and a greater percentage of time of CPP below the lower limit of autoregulation. And this association, as you can see here, remained persistent even when they did a multivariable logistic regression analysis with mean ICP for prediction. Hence, so sorry, sir, the previous, can you go back to the previous slide? You can also see the third figure where the temporal profile of the lower limit of autoregulation is shown here. Now, the blue represents those with a favorable outcome and the red represents those with an unfavorable outcome. As you can see, the favorable outcome is relatively stable, whereas the unfavorable outcome, shows a greater temporal variation. So this pattern suggests that you need a greater increased CPP requirement to maintain adequate cerebral blood flow. And also one extra point is they found that the lower limit of autoregulation exceeded 50 millimeters of mercury or more in 35% of the patients, notably more so in older children more than 8 years. So the current BTF guidelines, which state that the lower limit is 40, may need to be revised given the results of this study. However, at the end of the day, despite carefully adjusting for prognostic covariates, their analysis is largely observational and therefore it identifies associations more than causal relationship. Now, our second article is on the lowering of acute blood pressure and the risk of ischemic lesions on MRI after intracerebral hemorrhage. Now, as we know, there are two schools of thought on lowering the blood pressure post ICH. One school of thought says intensive lowering of blood pressure to 140 is safe, while the other says have a more conservative approach and keep it less than 180. Now, what this study was based on, it's an MRI-based study where they indicated the lesions, the incidence of lesions on diffusion-weighted MRI imaging, and they found that, as you can see in this figure, the number of diffusion-weighted imaging lesions and the total volume of DWI lesions showed no difference in both the groups. So they categorized that it is safe to lower, intensive lowering of blood pressure is safe post ICH. So now that we know how much to lower the blood pressure, let's see when should the blood pressure be lowered. So moving on to a third article. Our third article addresses when should we safely lower, the next slide, sir. Right, so a third article assesses when should we safely lower the blood pressure. Now in this study, the effect, they found that lowering the blood pressure to less than 140 showed a functional recovery of decreasing levels of functional recovery with increasing time from onset of symptoms to randomization. So compared with the guideline group, that is the guideline group is less than 180, whereas the intensive group is less than 140. So compared with the guideline group, the intensive group had significantly improved functional recovery in patients who received the targeted blood pressure within 3 hours of the onset of ICH. So this finding underscores the highly time-sensitive nature of the treatment of intracerebral hemorrhage, which is, kind of similar to the reperfusion therapy, that the timing of reperfusion therapy that we recommend for acute ischemic stroke. Also, they found that the odds of having a poor functional recovery, assessed by an MRS of 3 to 6, was significantly reduced in patients having intensive BP lowering. And also another study which supports this concept is the INTRACT 4 study, which showed that ambulance delivered BP reduction in hyperacute stroke within 2 hours of onset of symptoms significantly improved outcomes in patients with intracerebral hemorrhage. Now moving on to the next article. So our next article is on the use of altiplase for acute ischemic stroke between 4.5 to 24 hours of onset. So this was the HOPE randomized clinical trial where patient received intravenous altiplase at 0.9 mg per kg with 10% given as a bolus followed by a 6-minute infusion of the remaining dose. And they found that this was in patients who had salvageable brain tissue and no initial plan for thrombectomy. This was the inclusion criteria. So they found that the use of altiplase significantly increased the rate of non-disabled, that is MRS of 0 and 1, non-disabled functional outcome. So altiplase was associated with a better functional outcome, the use of altiplase. However, they also found that the incidence of symptomatic intracranial hemorrhage was significantly higher with altiplase, that is 3.8% compared to 0.51% with the standard prevailing treatment. So, it needs to be taken with a pinch of salt, and, you need larger studies to conclusively establish the utility. So our next article was on, right. So our next article is an exploratory analysis of chemical and mechanical venous thromboembolism prophylaxis in patients with high rebleeding risk of traumatic brain injury. So current evidence, that is all the recent studies, suggest that initiating thromboembolism prophylaxis within the first 72 hours of injury significantly reduces the risk of venous thromboembolism without increasing the risk of rebleeding. However, as we all know, in clinical practice, it is usually delayed, sometimes even up to 2 weeks, due to concerns about exacerbating the existing ICH, especially in these high-risk patients. So to address this, the American College of Surgeons, they recommend the use of the modified Byrne-Norwood criteria, which has stratified traumatic brain injury into low, moderate, and high intracranial hemorrhage risk based on the hemorrhage size and type. However, even these guidelines do not tell us exactly when to time the initiation of venous thromboembolism prophylaxis in high-risk patients. So we often tend to err on the side of caution, increasing the risk of thrombosis or pulmonary embolism. So this was a retrospective study which analyzed the American National Trauma Data Bank. It was based on more than 700 trauma centers in the United States. So the retrospective study of more than 13,000 patients. So they found that there was no difference in the mortality whether you initiate thromboprophylaxis early versus late. However, they found a significant reduction in the ICU stay on an average by almost 3 days in patients without any pre-existing anticoagulation or bleeding disorder in the very early, that is less than 24 hours administration group of venous thromboembolism prophylaxis. And also they had a shorter ICU stay. So no direct correlation with the mortality or the functional outcome, but a significant reduction of the ICU stay and ventilator stay. However, at the end of the day, it's a retrospective cohort design. It's not able to account for variations in the individual hospital protocols, given that there were more than 700 centers. So significant variations in the hospital protocols, which can vary widely and impact both the administration of prophylaxis and the patient management. So our next article is on, right. So our next article is on the novel Pillar XT system. So as we all know, the blood in the cerebrospinal fluid space has contributed significantly to deleterious outcomes in patients with aneurysmal subarachnoid hemorrhage. And this study assessed the extracorporeal filtration of CSF and the functional outcome of patients with aneurysmal subarachnoid hemorrhage. So, wherein after securing the aneurysm, they inserted a dual lumen intrathecal catheter and they performed an extracorporeal filtration of 72 hours of the CSF, thereby removing blood products from the basal cisterns and reintroducing the filtered CSF into the thoracic subarachnoid space using their novel neurapheresis CSF management system. Later, they performed neurological examinations every 2 hours, CT scans, and took CSF samples for analysis. Now, they found this was a very small study, exploratory study in 27 patients, and they found that the red blood cell, the protein counts in the CSF reduced significantly. So, RBC count, as you can see, reduced up to 86%, and the protein count, as you can see here, reduced to 82% as compared to the standard care, patients treated in standard care without any extracorporeal filtration. And also the intracranial quantity of blood evaluated by the Hijra sum score decreased by more than 65%. However, we need to keep in mind that this study showed 5 important adverse effects. 4 were minor. It was headache and back pain in the back and in the limbs. One patient showed signs of transtentorial herniation. So this was one significant adverse effect in 27. So we do need larger studies to assess the incidence of these serious sequelae. So final article today is based on, so next slide, yeah. So final article today is based on a new characterization of acute traumatic brain injury. As we know, the clinical severity of TBI is commonly classified using the Glasgow Coma Scale as mild, moderate, and severe TBI. Now, although the GCS scale remains highly relevant to clinical practice, using it to group patients into just 3 broad categories has substantial limitations. Now, first of all, this kind of tripartite categorization results in loss of crucial information, right? So, second thing is it is unimodal. It is based on a single clinical parameter and it ignores other imaging or blood-based biomarker. And third, some amount of bias may be introduced due to this nomenclature. For example, patients with mild TBI may not be intensively monitored, and patients categorized as severe TBI might not receive, standard care, and it might lead to premature withdrawal of life-sustaining treatment. Therefore, the National Institute of Health, collaborating with the National Institute of Neurological Disorders and Stroke, they launched this initiative to address this need to characterize TBI with a focus in the acute phase. This is an acute phase classification, right? So they have recommended classifying TBI based on 3 pillars. One is the clinical pillar. The clinical pillar is based on the GCS and the pupillary reactivity score. The second pillar is the biochemical pillar, which is based on the blood-based biomarkers. They have used 3 biomarkers, that is the GFAP, the UCHL1, and the S100 beta, based on various validated studies. So use of 3 biomarkers. And the third pillar is the imaging pillar with its focus on CT imaging parameters. I'm not going to go into detail. However, they recommend, now as we all know, both these biomarkers, that is the GFAP and UCHL1, has now been cleared by the US FDA, and also they are CE certified in Europe as well. So these biomarkers add value for predicting which patients might actually require a CT scan. In addition, now the clinical pillar is used as the first priority in all patients. Now, in patients in whom a definite clinical indication for imaging exists, the imaging pillar takes precedence over the biomarker pillar. So it's not always done in the same order. Nevertheless, the biomarker pillar remains relevant from a prognostic perspective, right? And in patients where the indication for imaging is uncertain, the biomarker pillar might take a greater relevance for providing the evidence of brain injury and to assess the need for CT scan. However, we all know that this characterization of TBI should be dynamic because patients change over time, and hence it is recommended to perform repeated assessments of the CBIM framework. C is the clinical, B is the blood-based biomarker, and I is the imaging framework. And there is some amount of uncertainty whether this CBI framework can be applied beyond the acute stage, and we need further research to determine the relative importance of their individual pillars in the subacute and chronic phase as well. Hence, the authors also state that they do not present this framework as a finished product, and this framework will require refinement and validation in larger studies before considered for implementation in clinical practice. However, this is an interesting perspective to characterize TBI. Right. So that brings us to the end of the journal watch and back to our article at hand. So this concept of remote ischemic preconditioning to prevent DCI has shown promising results in cardiac and vascular surgeries. However, this concept of mitigating reperfusion injury and providing neuroprotection in aneurysmal subarachnoid hemorrhage has not yet been conclusively proven. I hereby welcome both our speakers, Dr. Amya sir and Dr. Shriyosi, to shed some light on this topic. So over to you, sir.
Thank you. Thank you so much, Dr. Ashwini, for enlightening us with the update on the recently published articles on neurocritical care. Now, in this journal club, we will first, Dr. Shreyosi is our DM resident at PGI Chandigarh, and she will first present the introduction, methods, and results. Subsequently, I will discuss the discussion part and critical appraisal of this article. So before starting, first of all, good evening to all the faculties and students. And we are really thankful to the team NCSI Bulletin for giving us this opportunity to present and critically analyze this article on remote ischemic preconditioning to prevent delayed cerebral ischemia due to vasospasm in the treatment of patients with aneurysmal subarachnoid hemorrhage. As Dr. Aswini have already highlighted the importance of remote ischemic preconditioning, we will see if this is helpful, this modality is helpful in case of aneurysmal subarachnoid hemorrhage patients or not. Over to Dr. Shreyosi, and she will present the article.
Good evening, respected faculty members and dear colleagues. Thank you for giving us this platform to present this article. So, aneurysmal SH triggers a cascade of pathological events, including cerebral vasospasm, DCI, and ultimately leads to neuronal injury and death. Reperfusion damage is a contributor to this cascade of injury following DCI. So, RIPC is a short, controlled period of ischemia followed by reperfusion in a tissue and has shown potential in reducing ischemia reperfusion damage in aortic and coronary bypass surgeries. So, the study population for this article was aneurysmal SH patients undergoing clipping or coiling, and the intervention provided was RIPC, and in the control group, it was without RIPC. The outcome that was assessed was new cerebral infarction on CT, and the time duration was 2 to 3 weeks after the bleeding event. So, coming to the hypothesis, RIPC provides neuroprotection by lowering the risk of cerebral infarction in aneurysmal SH patients. The aim of the study was to investigate whether RIPC could reduce the occurrence of cerebral infarction as an objective surrogate marker of DCI. Coming to the primary outcome measures, new cerebral infarctions defined on follow-up CT scans 2 to 3 weeks after the bleeding event were the primary outcome measure. Cerebral infarction was taken as a new area of hypodensity within the cerebral parenchyma in comparison to the routine CT scan on admission. Coming to our secondary outcome measures, the incidence rates and severity of neurological deficits were taken. TCD velocities were measured daily between day 3 to day 21. Flow velocities were recorded in the MCA, ACA, and ICA. MRS scores were recorded at hospital discharge and at 6 months. Motor function was assessed using the Medical Research Council muscle strength grading system. So, coming to the methodology for the study. So, study design, it was a single center, randomized, double masked, parallel, control trial, which was done between November 2019 to October 2023 after receiving ethical approval. Informed and written consent were taken, and the trial was registered in the German Clinical Studies Registry. There were two groups, the RIPC group taken as the intervention group and the control group. So, coming to the inclusion criteria, patients presenting with aneurysmal SH who were more than 18 years of age, and after ruptured aneurysm has been confirmed through CT angio or DSA, and occlusion has been done at the center. Patients who were excluded were less than 18 years of age or pregnant patients, patients with peripheral arterial disease, diabetic patients requiring oral antihypoglycemic agents, and symptom onset that was more than 48 hours before admission. So the statistical power was taken as 80% with a significance level of 0.05. 30 patients were enrolled in each group to account for dropouts. This was based on a previous article by Salas et al. 1:1 ratio was used using a computer generated randomization list. Randomization sequence and group allocations were assigned by an independent researcher. Assessors for evaluating the outcomes were masked. So we had 60 patients who were randomized into two groups, the RIPC being the intervention group, and 29 patients were in the RIPC group, and 31 patients were allotted to the control group. So we can see in the RIPC group, we had 3 inflations of BP cuff, which was done to 20 mmHg above the systolic blood pressure. Each inflation was for 5 minutes, which was followed by again 5 minutes of reperfusion. And this was done once daily for 10 days starting after the treatment. And outcome assessed was new infarct on CT, TCD velocities, MRS, and neurological deficits. Similarly, in the control group, we had BP cuff, which was placed on the upper arm, but no inflation was performed. And here also, new infarct on CT, TCD velocities, MRS, and neurological deficits were assessed. So statistical analysis was done using SPSS software. Categorical variables were analyzed using the Pearson test. Continuous variables were assessed for normality using the Shapiro-Wilk test. For normally distributed data, an independent samples t-test was used. The Mann-Whitney U-test was used to compare non-normally distributed data. Multivariable analysis was performed using logistic regression models for binary outcomes and linear regression models for continuous outcomes. P-value of less than 0.05 was considered as statistically significant. So coming to the results of the study, so this shows the demographic, which in both the groups it was comparable. We had 74% patients in the control group who were female and 62% who were female in the intervention group. Now it is interesting to note here that in the Hunt and Hess grade, we can see that Hunt and Hess grade 4, the number of patients in control group, 45% patients of Hunt and Hess grade 4 we can see here, and in the intervention group we have only 20.7 patients from Hunt and Hess grade 4, while here the maximum number of patients from Hunt and Hess were from Hunt and Hess grade 2. Remaining variables were comparable. We had comparable data between coiling and clipping as well as for location of the aneurysms. So the most common symptom among both the groups was a typical thunderclap headache, which was reported by 60% of the patients. Decreased vigilance was seen in 43% of the patients, and nausea or vomiting was seen in 32% of the patients. Other symptoms which were seen in these group of patients was meningism in 18% of the patients, focal neurological deficits in 15%, and seizures in 12% of the patients. 17% of the patients collapsed shortly after admission. So, coming to the tolerability and safety of RIPC. RIPC was initiated after the occlusion of the aneurysm with a median delay of 2 days between aneurysm securing and the first session. So, the adverse effects that were noted were mild in nature. So, there was mild swelling of the arm in one patient, mild paresthesia of the upper limb in two patients. Pain in the upper limb was noted in one patient, and one patient complained of headache. All these had resolved in under 15 minutes and required no further treatment. So, coming to our primary outcome, 20% of the patients are new infarct on post procedure CT. Both the groups exhibited a similar occurrence rate of infarcts. In the RIPC group, it was 24%, whereas in the control group, it was 16%, and the p value was 0.44, so it was not statistically significant. Coming to our secondary outcome, which was the TCD velocities. So vasospasm defined as TCD velocity more than 200 centimeter per second. This was seen in 48% of the patients in the control group and 37.9% of the patients in the RIPC group, with a p-value of 0.62 between the two groups. Cerebral vasospasm occurrence was comparable, 74% versus 75.9% in the other group. So here we have two clustered bar, which is showing the green denoting the intervention, whereas the yellow denotes the control group, and we can see that the occurrence of cerebral vasospasm are comparable between both the groups. So at TCD velocities less than 120 centimeter per second, new infracts were observed in 62.5% of the patients in the RIPC group and 50% of patients in the control group. At moderate TCD elevations, new influx occurred in 57.1% of the patients in the RIPC group compared with 81.8% in the control group. For TCD velocities which were higher, that is at 200, more than 200 centimeter per second, we had new influx which were detected in 58.3% of the patients in the RIPC group and 85.7% in the control group. So here we have this clustered bar which is showing the TCD velocity. So on the x-axis we have the TCD velocities, and on the y-axis we have the percentage of patients with the new influx. So here also similarly we have the dark green shade which denotes the intervention group and the yellow which denotes the control group. So here we can see that in the velocities, if the velocities were less than 120, we have almost similar number of patients in both the control and the intervention group. Now when we are in the 120 to 200 centimeter per second subgroup, we can see that the number of patients are slightly higher in the compare group compared to the intervention group, and in the group that was more than 200 centimeter per second, similarly we can see a higher number of patients in the control group compared to the RIPC group. Similarly, we can see in this line graph that the yellow denotes the control group, whereas the green denotes the intervention group, with the velocities being represented on the x-axis and the percentage of patients with influx on the y-axis. So here we can see that the green, which is denoting the RIPC intervention, the number is comparatively lower compared to the one with the control group, although this has not come out to be statistically significant. So, coming to the secondary outcome, which was the neurological deficits and mortality, new neurological deficits occurred in 6.9% of the patients in the RIPC group and in 9.6% of patients in the control group. 6 patients, which comes to 21% approximately in the RIPC group, and 4 patients in the control group had died during the period of hospital stay. So, similarly, in this clustered bar, we can see that the green denotes the, so we have these two groups, which is the intervention and the control group, and we have the green which denotes the patients who had passed away, and yellow denoting the patients who are alive. And the number of patients who had passed away in the RIPC group appears to be slightly more compared to the patients in the control group. And this is the Kaplan-Meier graph that we have here, where the green denotes the intervention group, which is the RIPC group, and the yellow, which is denoting the control group. So here both are starting at the same level, which is at 100% probability of survival. And following that, we have a step down, which denotes an event, the event being death in this. So we can see that there is not much of a difference between both the interventions and the control group. So, coming to the functional outcome and disability, similar median MRS were noted in both the groups at discharge and at follow up. So, the median MRS at follow up, however, had improved compared to at discharge. So again, in this clustered bar, we can see that green is denoting the RIPC group, as well as yellow is in the control. Yellow indicates the control group, and the number of patients here we can note that in MRS 5, we can see that slightly higher patients were in the control group compared to the RIPC. Other than that, both of them appear to be almost evenly distributed. And this is for MRS at follow-up. We can again see that the green, which is denoting the RIPC, and yellow, which is denoting the control group. So here we have patients at MRS of 0, 1 and 2, which is almost equally distributed. And in MRS of 3 and 5, we have no patients in the intervention group. Both patients were from in these two groups, patients were from the control group. So I'll hand over to Amya sir for the discussion.
Thank you so much, Dr. Streyasi. Now, since we are aware of the methods and results obtained in this study, I shall be discussing the results and subsequent literatures on this particular topic. As we know, subarachnoid hemorrhage is the bleeding or the rupture of the cerebral blood vessel leads to release of blood into the subarachnoid space, causing subarachnoid hemorrhage. And once the blood is there in the subarachnoid space, that causes cerebral vasospasm. The treatment modalities that we have basically intends to prevent the cerebral vasospasm and thus re-establishing the cerebral blood flow into the hypoperfused part of the brain. Now, during the reperfusion phase of cerebral vasospasm, there occurs re-establishment of the blood flow. Along with that, there occurs supply of oxygen as well. That leads to release of oxidative free radicals, thus causing oxidative stress and secondary brain injury. Now, this remote ischemic preconditioning basically targets the reperfusion injury. In this study, the remote ischemic preconditioning did not seem to have a significant impact on the development and occurrence of cerebral vasospasm or cerebral infarction. Although the DCI is commonly defined as clinical deterioration due to cerebral ischemia, in this study, radiologically confirmed cerebral infarction was taken as the objective and standardized endpoint. The reason was very simple. The clinical deterioration could be confounded by the sedation, level of sedation which is given in these patients. Along with that, the deterioration which occurs because of the primary pathology that can also affect the clinical diagnosis of DCI. As I have already highlighted, the reperfusion damage following vascular ischemia during DCI or secondary infarction causes neuronal injury, which is characterized by production of reactive oxygen species, activation of complement system, adhesion of leukocytes to endothelial cells, aggregation of platelets and leukocytes, increased microvascular permeability, impaired endothelial dependent vasorelaxation. Now, this remote ischemic preconditioning that we have basically tries or addresses all these factors. Although the exact mechanism of action of remote ischemic preconditioning is still unknown, but researchers, they have opined that it acts through three mechanisms. First one is neuronal, in which it acts upon the preganglionic nerve, ganglion, and postganglionic nerve. Next is humoral mechanism, through which the ischemic insult which is given at a remote site causes a release of endogenous autacoids like adenosine bradykinin, which flows through the blood and reaches distant target site like heart, brain, kidney, and liver, thus giving or generating a protective mechanism against the future ischemia or infarction. And the third mechanism that we have is systemic mechanism, that is anti-inflammatory mechanism. Through this, The remote ischemic insult causes activation of anti-inflammatory mediators and inhibition of inflammatory mediators, thus creating a state of or reduces the state of inflammation, thus protecting the target organ. We have now we should know what is a remote ischemic preconditioning, what is perconditioning, and postconditioning. The remote ischemic preconditioning is in remote ischemic preconditioning, the ischemic insult is applied in a remote area before the development of ischemia. In perconditioning, this stimulus is given at the time of ischemia, and in postconditioning, the ischemic stimulus is applied during and after reperfusion. Coming to the history of remote ischemic preconditioning, it was first discovered by Murray et al. Long back in 1986, and they coined the term ischemic preconditioning. Subsequently, in 1993, President et al. Used the term remote when they observed that cross clamping on the right side of the heart protected the left side of the heart. Subsequently, in 2002, Raj Kharbanda et al., working at the Hospital for Sick Children in Toronto, showed that non-invasively stopping and starting of blood flow in the arm provided the same protection as invasive preconditioning of the heart. The beneficial role of remote ischemic preconditioning in reducing myocardial infarction has been proven among patients undergoing cardiac surgery, which could be coronary artery bypass graft or valve replacement. This was a study published in Lancet by Drake et al., who evaluated the effect of remote ischemic preconditioning on myocardial injury in patients undergoing coronary artery bypass graft. And they found that remote ischemic preconditioning significantly reduced the overall serum trough T value at 6, 12, 24, and 48 hours. Thus, concluding that this modality has a beneficial role among patients undergoing coronary artery bypass graft, and it protects the heart from future myocardial infarction. Similarly, another study by Thielman et al. Published in Basic Research in Cardiology, and they found the same conclusion, and they concluded that remote ischemic preconditioning is quite beneficial for patients undergoing cardiac surgery. Now, research involving this remote ischemic preconditioning for cerebroprotection has evolved over the last few decades. Few studies with small sample sizes or pilot studies have evaluated its role in various neuropathologies, but without a consensus. This was an article by Raval et al. Published in Neurocritical Care, which evaluated the remote ischemic preconditioning in subarachnoid hemorrhage. And they included the patients in two groups. One group was a high pressure occlusion group, another one was a low pressure occlusion group. In high pressure occlusion group, they inflated the blood pressure cuff in one of the arm to a blood pressure in which it caused loss of distal pulses. Whereas in low pressure occlusion group, the cuff inflation was with lower pressure while preserving the distal pulses. And they found that in low pressure occlusion group, the overall incidence of vasospasm was less. The hospital and ICU stay was also less in lower pressure occlusion group. So they concluded that this remote ischemic preconditioning is a feasible and safe option among patients with aneurysmal subarachnoid hemorrhage. Now, this is a study by Niman's team led by Dr. Sangeeta, who evaluated the effect of remote ischemic preconditioning on cerebral vasospasm, biomarkers of cerebral ischemia, and functional outcomes in aneurysmal subarachnoid hemorrhage, IRVAS trial. And they used serum biomarkers like ACE100 beta and neuron-specific enolase in their study. They had two groups. One was a true RIPC group in which the blood pressure curve was inflated 3 times to 30 millimeter of mercury above the systolic pressure for 5 minutes, followed by 5 minutes of reperfusion. Another group was a SAM RIPC group in which the blood pressure curve was inflated to 30 millimeter of mercury for 5 minutes. They found significant improvement in vasospasm along with the length of stay of the patients and higher extended Glasgow outcome scale values in true RIPC group compared to SAM RIPC group. So that's why they concluded that RIPC is a feasible and safe option in aneurysmal subarachnoid hemorrhage patients, and it results in lower incidence of vasospasm and better functional outcome. The same group of authors, they did a secondary analysis of the primary study, and this time they evaluated the effect of remote ischemic preconditioning on cerebral oxygen saturation in aneurysmal subarachnoid hemorrhage. And they found it to be beneficial with significant reduction in cerebral oxygen desaturation incidence in true RIPC group compared to SAM RIPC group. Another study by Sales et al. And they highlighted the importance of this ischemic preconditioning on surgical treatment of brain tumors. And a Cochrane review published by Zhao et al. And they evaluated the remote ischemic conditioning for preventing and treating ischemic stroke. But however, they found low quality of evidence supporting the role of remote ischemic conditioning among patients with ischemic stroke. Now, let's know what are the limitations of this particular study. This was a single center study with a small sample size. The optimal ischemic dose of RIPC was unclear in the study methodology. Aneurysmal subarachnoid patients may need a more intense or prolonged stimulus to achieve neuroprotection. Use of CT, instead of CT, they could have used MRI for better evaluation of the ischemia. Although they have used the TCD, only mean cerebral blood flow velocity was measured, and there was no information on the Lindegaard ratio and pulsatility index. And lastly, they have done only a subgroup analysis of the patients with TCD velocities more than 200 centimeter per second. Now, to conclude, the remote ischemic preconditioning has a limited effect on the occurrence of vasospasm as measured by TCD velocities, or on the development of new cerebral infarctions on CT imaging in patients with aneurysmal subarachnoid hemorrhage. But having said that, considering the potential promising role of this treatment modality, large multicentric trials involving larger sample size would generate a robust evidence in support of remote ischemic preconditioning. Now let's discuss the critical appraisal of this particular article. Now, did the study addresses a clearly formulated research question? Yes. Was the assignment of participants to intervention randomized? Yes. Were all participants who entered the study accounted for at its conclusion? Yes. Were the participants blind to intervention they were given? The answer is can't tell, because in both the groups they have said that both the group of patients, they were exposed to same interventions. But however, after going through the methodology, we found that in one group the blood pressure curve was inflated, but in another group the curve was not inflated. It was just kept attached to one of the arm. The next is where the investigators blind to the intervention they were given to participants. Again, can't tell because of the same reason. Where the people assigning analyzing outcomes blinded? Yes. Where the study groups similar at the start of the randomized control trial? Yes. Apart from the experimental intervention, did each study group receive the same level of care? Yes. Were the effects of intervention reported comprehensively? Yes. Was the precision of estimate of the intervention or treatment effect reported? Yes. Do the benefits of experimental intervention outweigh the harms and costs? Yes. Can the results be applied to your local population or in your context? Yes. Would the experimental intervention provide greater value to the people in your care than any of the existing interventions? No, because more research need to be carried out before um, concluding that RIPC is better than the existing treatment. Thank you so much.
Right. So thank you to both our presenters for very clear and insightful discussion of this important study. I think you've highlighted not only the important findings, but you've also performed a very comprehensive critical appraisal. So thank you to you both. We appreciate the time and effort you put into preparing this presentation. So we'll now open the floor for all questions. So we already have some questions. So Dr. Prithvi has asked, Dr. Amya, can you please explain again remote ischemic perconditioning versus preconditioning?
Okay. I have already mentioned that remote ischemic preconditioning means the stimulus is applied at a remote site, preferably at arm, before the development of ischemic episode or before the anticipated infarction or ischemia or infarction episode. That is remote ischemic preconditioning. But when there is ongoing ischemia or infarction, if we are applying the same, then that is known as a remote ischemic perconditioning.
Okay, right. So do you think, given the small sample size of the study, so adding some blood-based biomarkers could have, helped clarify if RIPC had a better, physiological effect on the occurrence of DIC?
Yes, definitely yes. The authors could have added brain biomarkers like S100 beta or neuron-specific knowledge. Although having said that, the study carried out by Dr. Sangeeta et al., they had included these biomarkers, but they could not find significant difference between the two groups. But again, considering the not so robust methodology of this study, I would say they could have added serum biomarkers for a more authentic result.
Okay. Sir, and if I'm not mistaken, I think the study included patients who underwent both clipping and coiling. So, they
Yes,
might have different varying effects on, occurrence of DCI and vasospasm. And they
yes.
didn't perform any subgroup analysis also, I think.
That's again one of the flaws of this study. The groups which were included were heterogeneous. As we know, the incidence and severity of vasospasm varies between the coiling and clipping a group of patients. So they could have included one group, either coiling or clipping, to make this in population homogeneous.
Or maybe a subgroup analysis. As they could have
Otherwise,
included
they could
both
have
and
carried out a subgroup analysis for a more insight into the, like incidence of vasospasm among two different group of patients.
patients. And somewhere it was given the assumed effect size in the sample size calculation was based on I think around 50% reduction in the
Yes.
incidence of infarcts. So isn't it
Yes.
like being overtly optimistic?
Optimistic because this is a newer modality, not yet established one. So if we are expecting this newer modality to be like more effective than the established treatment protocols, then that's really optimistic. And in fact, that could have also affected the sample size, final sample size calculation. That's why this study seems to be underpowered to obtain significant results in support or against RIPC.
And randomization was not stratified by some very well-known markers of DCI, like Fisher's
Yes,
grade or location of the aneurysm or Hunter-Ness. They could have done this.
yes.
This might increase a baseline risk, baseline imbalance in the population.
Yeah. Actually,
Right.
in demographic table, we could see that this looks, I mean, the Hunter-Ness group of patients looks comparable between the two groups. But if you'll go through minutely, you'll find that in intervention group, there are more grade 4 patients compared to grade 2 in case of control group. So that would have affected the final result as well. Though
Right.
it
So
looks
baseline imbalance.
statistically, yeah, it looks statistically insignificant, but could be clinically significant.
significance. True, very true. Okay, so Dr. Prithvi has another question. So if we need to plan further studies on this topic like RIPC, what changes in the protocol do you recommend?
I think they should have standardized the curve inflation. Although in different studies they have taken different blood pressure inflation, but they could have taken like maybe 20% more than the systolic blood pressure, or exactly just like Dr. Sangeeta, they have included more than 30 millimeter mercury above the systolic blood pressure, and in another group they have included only 30 millimeter of mercury. So that would have made it randomization would have been easy. I mean, blinding would have been easy in that case. Um, Along with that, they could have added some serum biomarkers. They could have
And
included homogeneous patients, I mean, group of patients, and in TCD value also. Although they have taken mean cerebral blood flow velocity, again PI and linear ratio could have also provided more meaningful insights into the study, and they could have used the MRI as well in place of CT, as we have already discussed in the limitations. Also, they have also mentioned the same. So, you know, combined
right,
altogether, the study methodology could have been improved. I mean, could be improved for future study.
future studies, right? So thank you, sir. I don't think we have any more questions. Right. So to conclude, RIPC is safe and feasible in patients with aneurysmal subarachnoid hemorrhage, but the current study revealed no clear benefit in preventing vasospasm or DCI. So this study actually underscores the complexity of DCI, where multiple mechanisms beyond large vessel spasm might be involved. So this was, in addition, a small single center exploratory design. So we should interpret the results cautiously, and we need future research focusing on identifying subgroups who would benefit or optimize the ischemic dose and protocol. So it highlights the need for larger multi-center trials with focus on high risk subgroups. Right. So thank you, sir. Thank you to both our speakers for the presentation, and I thank the audience for patient listening. So thank you so
Thank you so
much.
much, Dr. Ashwini. Thank you so much. Team NCSI.